I'm pleased this morning to introduce Dr. Kwan, who is visiting us from the University of Virginia. He has established himself as sort of a unique sort of perspective. He has boards in just about everything, but he started in critical care, did sleep medicine, and then finished up with a cardiology fellowship at the University of Minnesota, and then has been on faculty out at UVA now for about 4 or 5 years. He's developed this unique interest in terms of cardiovascular physiology and sleep medicine is known to our sleep doctors. He's funded by the NIH to pursue these studies and has an extensive sort of publication list in looking at the interaction between cardiac physiology and sleep medicine. And so we are honored to have him come and talk to us today and look forward to his talk. So thank you.
Thank you, Dr. McLellan, and thank you all to be present here on Friday early morning. Hopefully I can make this 1-hour session useful for you. Some disclosure, but no relevant disclosure. So we all know that sleep is very important. Hopefully you had some sleep last night. I won't talk about this too much, but we all know that sleep is very important in maintaining health and homeostasis in human beings. So my 2 objectives are to understand the key evidence and knowledge gaps behind the association of sleep and cardiovascular disease, which has been a popular topic, at least in the sleep medicine field in the past couple of decades. So we'll just kind of go over some of the overviews on that topic, and also recognize the emerging science behind sleep and cardiac arrhythmia, focusing on atrial fibrillation. So this will be my structure of talks. Okay, so pre-test question. Which of the following cardiovascular conditions has the strongest association with untreated obstructive sleep apnea based on the current evidence? Okay. So think about that question a little bit. I do have an answer in my mind. We can make argument on each of these conditions, but we'll talk about this. So first case, 45-year-old man for annual physical visit to your office. No complaints, no meds. Some family history. BMI on the higher end. Large neck circumference that are not uncommon in our practice, but he's healthy otherwise. Exercise on a regular basis. So the patient wants to be proactive in prevention of cardiovascular disease, given strong family history. What follow-up questions would you additionally ask? Okay, so just think about that a little bit. You're in busy practice. You don't want to extend your time too much, but you want to probably throw one, or a couple of key questions that may be helpful. So he says, his sleep is not bad. Loud snoring at times, and feels tired occasionally. And this is average response that you get. Okay, portable sleep study was done, home sleep study was done, and the patient, and you get the report from your colleague, says severe sleep apnea, apnea-hypopnea index of 42, but notably marked oxygen desaturation, as you can see here on the slide. And sleep specialists recommend CPAP therapy. So the patient says, I don't like to wear the CPAP. What will be the potential consequences if I don't do anything? So that's also a very common response that I get. So first study I'd like to kind of go over is a landmark study, in my opinion, from Wisconsin Sleep Corps study published in New England Journal of Medicine 2000. This was a study looking at, from general population, whether having baseline sleep apnea predicts new onset hypertension down the road. So these are people from community who do not have history of high blood pressure at baseline, but they followed for a number of years. And what they found was that if you have sleep apnea at baseline, and especially the thing that's interesting is there's some dose-response relationship. But if you have severe sleep apnea, for example, here in this column, you have about 3 times high odds of developing new onset hypertension. So to answer that question from that patient, we can potentially cite this paper and tell them you don't have high blood pressure, you're pretty healthy, but there are studies out there that look at the incident hypertension if somebody has a sleep apnea. Of course, this study has been kind of debunked by other subsequent studies, one way or the other, but I think this at least itself holds a truth, and it's a very large study that's difficult to replicate. This is a study from Spain. This is another cohort study where they showed that if you have a severe sleep apnea during follow-up, your chance of developing new onset high blood pressure is higher. And what they also noted was those who were actually treated with CPAP, so this was not a randomized trial or anything, but an observation study, but if you look at the group that were treating themselves with the CPAP, there was some reduction in incident hypertension, suggesting that there may be some therapeutic effect, and also reinforcing that maybe there's some causal relationship. The most focus on hypertension has been around resistant hypertension, just because it's not uncommon, number one, and also number two, very difficult to treat. They're already on a number of blood pressure medications. So many people hypothesize that people with resistant hypertension have coexisting sleep apnea, and that if we treat that, for example, with CPAP, it may add some benefit in terms of blood pressure management. Here I'm showing that this is a fairly short-term follow-up study, but you're looking at some modest blood pressure improvement with a CPAP in patients with resistant hypertension. Now, this type of modest blood pressure improvement seems like it's common in every other studies that use the CPAP as a therapeutic tool in patients with high blood pressure. I don't know what it is about 3, but most of the studies have shown about 3 millimercury change. So that's very modest, I would say. You can add another blood pressure medication and perhaps achieve this, possibly. So just to denote that there's no miracle here by using CPAP in resistant hypertension. Of course, there's a public health implication, even with this small dose response, but it's important to note that the response is not striking. And of course, this is a patient with a resistant hypertension, so you don't have much room to add. So it is remarkable in another sense. So Dr. Somers at Mayo Clinic, who kind of leads this science, at least in this country, has published this experimental study in a human being in the 90s, and showed this in Journal of Clinical Investigation. When you're awake, the sympathetic nervous activity is heightened. During sleep, and this was from a patient who had sleep apnea, during REM, rapid eye movement sleep stage, you can see the surge of sympathetic nervous activity. And then this was blood pressure measured non-invasively with a FinaPress, I believe, showing the fluctuation of blood pressure along with these events. You can see that the blood pressure in this case goes all the way up to 200. Of course, this is probably one of the best samples that he had, so bear that in your mind. So this is a portable. We're doing more portable sleep study because it's cost effective, and it gives you fairly effective results. pretty robust. So we're using this more and more. But you can see that you don't need to look at the remarks on the results section. Just looking at the oxygen saturation pattern. So this is in a way, glorified overnight pulse oximeter on steroid. There's some other measurements, but at the end of the day, we all sleep docs, their eyes on SpO2 trend first. And you can see that this patient, for example, has a very marked desaturation, periodic desaturation. Of course, this is a portable sleep study, so we don't have a sleep staging or et cetera. I can only guess that perhaps this is during REM sleep, or in this case, we don't have a sleep position marker. So I have to guess that this might be when you're in supine sleep or supine plus minus REM sleep, when you're most vulnerable in terms of sleep apnea. Now, look at this patient. It's a similar apnea-hypopnea index, if you will. However, the oxygen desaturation is not very remarkable. If I see this type of study, I question myself, does this patient really have a sleep apnea? So just contrast these two studies. So one of my arguments is that, okay, it's heart rate, and all this is good, snoring signal, and these are all good. But what about a simple parameter, as we understand, as blood pressure? We don't measure that, and there are no easy means to measure blood pressure at night. The current methodology of measuring blood pressure is the ambulatory blood pressure monitoring, which is still cuff-based, which recycles every now and then, half an hour. That itself is known to disrupt one's sleep. So perhaps not a good tool. So we don't really have that measure. And polysomnography itself, the paradigm hasn't changed in the past 5 decades. We're using the same technology, same concept, still into 21st century. But again, at the end of the day, we look at our eyes on the oxygen saturation pattern. But again, this patient, kind of contrast, which we see all the time. So this is the hypnogram of PSG, a snapshot. If you have looked at this during your medical school and your training, you will know that this is the sleep stages, color-coded, and there are event markers. And this is SpO2, the holy grail that we always focus on, and this is body position. So this was in-lab attended polysomnography data. So does it look impressive to you, or a little boring? As I said, the SpO2 is the one that you want to look at. I mean, there's maybe some fluctuation of saturation, but as you can see that they are mostly above 90%, not very obvious. And during REM sleep, where you're most vulnerable to have sleep apnea, there's not much going on. Okay. So by the way, the apnea-hypopnea index was 3 per hour. So by convention, of course, there are different scoring rules and whatnot, but that's another discussion. You'll say, well, this patient doesn't really have sleep apnea, so good. So this is the same patient that we are doing some pilot studies using a non-invasive blood pressure measuring tool that's not a cuff-based, but it's a finger pressure via finger pressure. It's FDA-approved device. So the same patient. So that same case 1. So this is the EEG airflow. That you can see that, by the way, each box is about half a minute. So you get the little time scale straightened here. You can see that there is some sleep apnea events here, here, and some corresponding desaturation. It does look like it's corresponding to these sleep apnea events, but if you look at the overall degree of desaturation, it's not that remarkable. It's still above 90%. But in this patient, the blood pressure did surge, not quite as what Dr. Summers illustrated in the 90s, but the blood pressure in this case does increase after the sleep apnea events up to about 160, and it comes down again and kind of natural fluctuation, but then with these events, the blood pressure rises again. Okay, same patient. I'm not changing my case yet. Same patient, a different timing. Had another apnea event, the desaturation, not marked, but you can see that this corresponds to this apnea event. There is some blood pressure surge, but not a lot. If you look at the scale, this is 120, this is 160. So some blood pressure surge, but not much. So let's look at this one, same patient. There's not much going on. As you can see the airflow, there's no sleep apnea event. No desaturation, nothing. But look at the blood pressure change that's happening in the background. So I don't know whether this patient is dreaming or, bad dream, nightmare, or, I don't whether there was no arousal for sure, but maybe there's something going on during this episode where you can see the distinct blood pressure change. Maybe you're called into your boss or something in your dream. It's just, not a good dream. Something is happening here. Okay, this patient have a sleep apnea. So 42-year-old man, BMI 37, large neck, on medications, now presents with the chest pain, but there are clear history that are supportive of having sleep apnea. So you send them for sleep study, and this is what you get. Clearly, you can see that looking at the SpO2 pattern, this is no-brainer. This is very severe obstructive sleep apnea. And this was so-called a split night study where you try CPAP therapy in the middle of the night. And you can see that in this patient, the treatment was very effective. As you can see that the oxygen saturation remained pretty normal throughout the rest of the night. And the CPAP pressure is increasing. And he's having good sleep if you look at the overall architecture. Now let's look at this patient, what's happening behind in terms of blood pressure. So this is during diagnostic stage, having constant sleep apnea event. Again, this is 36 seconds. So, I would call this more of hypoxemia, but still it's a fairly long event, up to about, easily half a minute. And there is corresponding desaturation following each of these events. Look at the blood pressure, systolic blood pressure change. I would not say that this is that impressive. This type of blood pressure change is not uncommon if you observe a lot of patients. There's just kind of normal background fluctuation of blood pressure. By the way, these are not those respiratory change in blood pressure. This is much longer, low-frequency blood pressure change. So I wouldn't call this, a respiratory variation of blood pressure, but it's something different that we don't fully understand. But the point I'm trying to make here is the blood pressure change is not very impressive, despite the fact that this patient has very, very severe sleep apnea. I would call this one of the most severe sleep apnea I've seen, actually, this patient of mine. So CPAP was started, and you can see that this is still during the initial titration period, and there are some events, not as bad, but some events, and there's some corresponding desaturation. In this case, there was some blood pressure surge up to about 140s from baseline of 120s. And you can see that the patient had respiratory event and had an arousal response. So the patient basically woke himself up. So this is during arousal followed by awakening. So he's not sleeping anymore at this point. And perhaps that's what it is, but the blood pressure has quite increased and seems to maintain that for a bit. So once the patient achieved the good titration with CPAP, you can see that his sleep is very well regulated. There's not much of change in oxygen saturation, but you can see the SBP change kind of fluctuating up and down, and not a lot. I mean, maybe it's scale that makes you think that there's a blood pressure surge and decrease, but some background change, but not much of blood pressure change. So one interest I have, and one I think that there's the gap that I think that the field has is despite the fact that nocturnal blood pressure is an important prognostic marker, cardiovascular marker, the way we measure, first of all, we don't do ambulatory blood pressure monitoring that often. I don't know about you, but I don't do it that often. It's cumbersome. And even when we do, there are a lot of issues with it. So this kind of illustrates that point. So the blood pressure was measured during sleep, and by that non-invasive beat-to-beat blood pressure measurement. So this red dot represents average blood pressure over half an hour. So this red data is truly continuous beat-to-beat blood pressure measurement. Averaging interval is half an hour. And this black dot represents snapshot. This is not a cuff base. It's still same tool. I'm just trying to illustrate the point. So if we just measure snapshot every half an hour or so blood pressure measurement, how it might give you bias. So in this particular patient, I wouldn't say it's strikingly different, but you can see that depending on what timing the measurement was made, there can be a fair amount of difference in blood pressure information that you will get. And this is just an example from 3 patients where you can see that the blood pressure difference between snapshot intermittent blood pressure measurement versus beat-to-beat continuous blood pressure measurement, the difference can be quite significant from time to time. And also it somewhat depends on the sleep state when you're awake versus, I don't think I have been able to show that yet, but I think I'm seeing that in some of my data set, that REM versus non-REM versus sleep, the difference might be more accentuated. So one of the works that I'm doing right now is to try to estimate, to derive estimated blood pressure from physiologic measurement called pulse transit time that some of you may be aware of. This pulse transit time can be derived from sleep studies as long as you have a PLATH signal and the ECG signal. But we can potentially use that pulse transit time and derive that to estimate blood pressure. So in this slide, I'm showing you that in this patient there was an apnea event, and the pulse transit time dropped quite significantly. Heart rate did increase, but not a lot. This is when the patient had an apnea event. But this estimated blood pressure derived from pulse transit time also showcased this surge in blood pressure. So now let's move our gear to other component of sleep a little bit. So I only have a couple slides. Sleep duration, sleep quality, these are all important elements within sleep that has cardiovascular implications. And of course, we're not really talking about the quality of life and well-being issues, but that's the most important aspect of all this. I think the cardiovascular implication is secondary in my opinion. But this was a recent study using National Health Registry, National Health Database of 70,000 people self-reported. But I chose this slide because there are many studies out there that gives you conflicting results. But I think this study does well illustrate, summarize well what this U-shape is all about. So in this case, people who slept 7 hours as a reference, if your sleep duration is shortened or lengthened, again, this is self-report, which in my opinion has its own very unique value than objective assessment, has higher risk of hypertension. This is cross-sectional, just association, but it comes from 70,000 large population and from people from community, highlighting the fact that the sleep durations are somewhat closely related. We don't know the causal relationship, but so that's one of the limitations of all these studies looking at sleep duration, sleep quality, and all these are, most of them are based on self-report subjective data, which in my opinion, is very important in and of itself. However, we're not considering sleep apnea and lots of other factors that are going into this, so it's hard to tease this apart. So just that's what I just mentioned. Okay. Just to illustrate the point of importance of sleep duration and sleep quality on subclinical cardiovascular conditions, this was a study from MESA that I was part of, that we were interested in looking at the objective sleep duration. So now I'm switching my gear to objective using actigraphy. This is not a one-night polysomnography data, but actigraphy, a 7-day average actigraphy, which gives you decent objective data regarding your sleep duration. And our question was how that was related to aortic stiffness using cardiac MRI that was used in the MESA study. This was a cross-sectional study, so with a grain of salt. But what was interesting was that, I'm sorry, so that's the next slide. So what's interesting is that as your sleep decreases less than 6 hours, your pulse wave velocity actually decreased, meaning that it's less arterial stiffness, which doesn't make the greatest sense. But we did garden variety of analysis, but all pinpointed toward the fact that if you sleep longer, conversely, your arterial stiffness increased, as evidenced by MRI-based pulse wave velocity. We didn't find any significant association with aortic distensibility and other measures of stiffness. Now, this study that just came out just recently from, I think Dr. Fuster, Valentine Fuster was involved in this cohort study in Spain, showing that if you sleep less than 6 hours in this study, that your non-coronary plaque burden increases. So this was a coronary plaque burden that was measured on with the ultrasound, 3D dimensional ultrasound of your carotid as well as your femoral artery. So this is more consistent with what most people will believe. Okay, if you sleep less, in women though, if you sleep long, there's something about it. But there's some U-shape going on, but some interaction by sex. But as a whole, if you sleep less than 6 hours, there was association with increased non-coronary plaque burden. So 65-year-old man, hypertension, type 2 diabetes, had a stroke, comes in for a screening. Your sleep study shows mild sleep apnea, most of the events when you're on your back. Patient's not excited about this CPAP business by any means. So your take. So this is common report that you get, mild sleep apnea. Patient is not so much complaining much. Wanted to at least share this trial that came out a couple of years ago, because this is one of the very few randomized controlled trials existing in sleep medicine, which the question was whether CPAP improves the outcome in patients with a secondary prevention cohort. So this was a study done, it was a multi-nation, although the bulk of study, the participants came from China, but I think the results were pretty consistent throughout. So the CPAP versus usual care, and their primary endpoint was composite endpoint of cardiovascular events. Again, this was secondary prevention studies, and published in NEJM, and there were a lot of anticipation out of this study, but the results were fairly neutral. So in terms of composite cardiovascular outcomes, there was not much of a difference between a CPAP and versus usual care. It's called a SAVE trial. Didn't really save us. So switch gear to heart failure. A couple of heart failure trials real quick for those who are in heart failure, advanced heart failure field, I guess. There's a number of trials existing and a number of trials that are coming out. But CAMPAP trial is one of the very first trials that came out from Canada, University of from Toronto, Dr. Bradley's group, where their hypothesis was that people with heart failure, so now switching gear to people with heart failure, if you treat them with a CPAP in patients who particularly have essential sleep apnea and chain stroke respiration, that you will have a better outcome. And there were some improvement in surrogate outcomes, as you can see, the LVEF and other measurements, but the overall the transplant-free survival was, there was not much of difference. So this was considered negative, one of the first negative randomized clinical trials in heart failure PAP trials. And of course, there's other trials that I'm going to show you. Serve heart failure trial that you may be aware of, where they used more advanced device called the adaptive servo ventilator, ASV. So it's a CPAP, but it has a pressure support that fluctuates to suppress chain stroke respiration. So very similar concept to CPAP trial, but they used ASV device, which is much more effective in suppressing central sleep apnea and chain stroke respiration. And this study shed some highlights and drew some attention because the results were not only negative, but there was actually some trend of more adverse outcomes in patients who received ASV therapy, and which led to kind of like black box warning for use of ASV. And so the ASV was getting very popular when I was in my sleep medicine fellowship, I would say 7, 8 years ago. But after this trial came out, it really cooled down. And Japanese group was one of those groups that studied this extensively, showing lots of benefits in terms of surrogate outcomes. But after this trial, it kind of cooled down. There are a couple other trials that are coming up, including this CAT heart failure randomized clinical trial that was already published. It was prematurely terminated based on SERVE heart failure trial, but this was in a way a little bit similar study, but very shorter follow-up. But what was interesting was the recent, actually my interest more was on this study, the secondary sub-study that led by Dr. Piccini, who did some secondary analysis where patients with heart failure who had AFib and who had a device, CIED, cardiac implantable electronic device, when they received ASV therapy, their AFib burden quite remarkably decreased versus no change or actually increase in optimal medical treatment alone. So there may be some benefit in this group as well, although again, this study was a negative study as well. Case 3. Okay, so let me just, for the sake of time. Okay, so yeah, so this patient is basically a patient with AFib, and sleep study was done. You can see that there's clear evidence of sleep apnea based on this, just looking at the SpO2, the trend. So the patient says, my sleep is not good, my quality is not good, I feel tired in the morning, but I will never wear that mask. Same patient, okay? So after the cardioversion AFib has come back and patient is symptomatic, so this was the very first study that showed that that if you have a sleep apnea, your recurrence of AFib is much higher after cardioversion, published in Circulation 2003 from Mayo Clinic, Dr. Summers. And also showed that compared to general cardiology patient population, if you have atrial fibrillation, your prevalence of, your chance of having sleep apnea is much higher. And the same group also published that using Olmsted County data, that if you have some signs of sleep apnea at baseline, your chance of having new onset atrial fibrillation, this is very hard to prove, only can come from Mayo Clinic using Olmsted County data, in my opinion. But and also I can see that they did a lot of, they look at various measures of sleep apnea measures, but they found there was something that if you have more decrease in your nocturnal oxygen saturation, that your chance of having new onset AFib is higher. This was a study that I was involved where we showed that after atrial flutter, so not AFib, after atrial flutter isthmus ablation, your chance of having atrial fibrillation is higher if you have a sleep apnea down the road. Okay, so just move on. So there are some basic experimental animal studies that tried to simulate sleep apnea in the rats, and trying to show that the electrophysiologic properties can be affected by having simulated sleep apnea events. In this case, Lintz et al. From Australia showed that, I think this was a pig study, where they manipulated trachea and created negative tracheal pressure and illustrated the shortening of atrial refractory period, thus perhaps make one susceptible to atrial fibrillation. Of course, the animal models has lots of limitations, but I think it's a good illustration of a potential mechanism. This is another study that came out very recently using rat, and this was a little different animal model than what I just showed you. There is no obstruction involved, but this is just a chronic intermittent hypoxemia model, which, by the way, is often used. Here you see that the susceptibility of atrial fibrillation increases after being exposed to chronic intermittent hypoxemia versus sham. And so the inducibility increases. But what's interesting in this study was that if you have a cardiac sympathetic denervation, the CSD, the cardiac sympathetic denervation, that effect may be mitigated, perhaps highlighting the potential mechanism through which the sleep apnea may mediate atrial fibrillation. Another interesting aspect of this study was that, because I'm very interested in blood pressure responses, the post-apneic blood pressure response also was accentuated in a model of chronic intermittent hypoxemia, but with combination of sympathetic denervation, that effect of post-apneic blood pressure surge was mitigated. A couple of controversial and some discussion point about obstructive sleep apnea versus central sleep apnea is in terms of atrial fibrillation. The reason that I'd like to mention this is many, well, we don't have many, two recent observation studies have actually shown that it's not so much obstructive sleep apnea, but a degree of central sleep apnea events that predicts incident atrial fibrillation in population cohort. So when we think about sleep apnea, we think about obstructive sleep apnea, and when we think about atrial fibrillation, we think about obstructive sleep apnea, not so much central sleep apnea. But the population data has not really proved that if you have obstructive sleep apnea, it increases the risk of new onset atrial fibrillation, which is hard to prove, and I totally admit that. But on the other hand, if you have central sleep apnea, so central sleep apnea is a little different manifestation, you have higher incidence of atrial fibrillation. Now there's a lot of behind the discussion and behind controversial points that needs to be made here, because a lot of these patients who are quote unquote central sleep apnea do have obstructive sleep apnea as well. They're not necessarily totally separated, because you can separate each event by the mechanism, whether that's obstructive versus central, but as a whole, a lot of these patients have both obstructive and central sleep apnea. So again, this study also from recent sleep heart health study cohort illustrates the point that if you have a central sleep apnea at baseline, your chance of having incident AFib is higher, but not so much obstructive sleep apnea. So just kind of bear in mind, it's not as straightforward. The strongest evidence comes from a number of observation studies in the past 10 years that have suggested that if you have untreated sleep apnea, your atrial fibrillation recurrence is much higher after pulmonary vein isolation, to the point that there is a couple of meta-analysis out there that summarize that if you have untreated sleep apnea, your chance of having atrial fibrillation recurrence after ablation is higher. And also, if the patient is using CPAP, the odds of having recurrence AFib seems to go down. So what about other sleep elements, such as slow wave sleep? Have you heard about slow wave sleep? Okay. So this is a slow wave sleep, basically low frequency based on EEG. That's how it is differentiated. It's a good sleep, in other words, very good sleep, slow frequency EEG, you're in deep sleep. Have you ever seen your spouse or your children, whoever, they're not waking up? I mean, you're waking them up because they're snoring or whatever. You're trying to wake them up, they're not responding. Of course, they can, they're good sleepers, but the chances they're in a very deep sleep. It could be a REM sleep, but it could be slow wave sleep. This is the sleep where siren goes off, your alarm, goes off. You don't have any memory recollection of it because you're in very deep sleep. So it's considered good sleep. There's consensus among sleep physicians that the more slow wave sleep you have, perhaps the more restorative your sleep might have been the previous night. In this study, this was a cross-sectional in MESA cohort. What we found was the more slow wave sleep you have, again, this is cross-sectional. I cannot derive any causal relationship here, but this was very apparent that the more slow wave sleep you have from, albeit this was a single night sleep study, the chance of having atrial fibrillation was much lower. It was sort of an incidental finding, but it was a hypothesis-provoking study. Having said that, some subsequent studies that recently came out from Health ER study from UCSF using different data source. So this was basically looking at the subjective sleep report based on Health eHeart study reporting system website. Many people associated the frequent nighttime awakening was associated with having atrial fibrillation. And then they used the cardiovascular health study, part of which originated from here is in Seattle. From that cohort, people who reported nighttime awakening also seem to have a high, now this is a prospective, at baseline seem to have a higher chance of having incident atrial fibrillation. So something about nighttime awakening in relationship with atrial fibrillation. Okay. So this is another study that just came out, hot off the press. Same group from UCSF using Health eHeart study data, open resource. And this was a study looking at the patient report of triggers of paroxysmal atrial fibrillation. So these are patients who already have established atrial fibrillation, and they reported what seems to trigger their atrial fibrillation episodes. And alcohol, caffeine, exercise, these were all on the high top list, but also lack of sleep was also one of the common association. Are there any markers in ECG that may suggest that you may have high predilection of having atrial fibrillation or even ischemic stroke? Those of you who are involved in perhaps stroke, seeing patients with stroke, you may know that there have been a number of studies that suggested that certain ECG indices such as P wave terminal force V1, which is defined as the negative component of V1 duration times the amplitude of negative component, which is considered the left atrial remodeling electrophysiological marker, is highly predictive of incident ischemic stroke, even after controlling for atrial fibrillation, suggesting that there may be something about electrophysiological change that's manifested in EKG that may signal the higher chance of having cardioembolic stroke in the future. So I also looked at this P-wave index, particularly P-wave terminal force in V1 in MESA, and found out that people with a higher degree of sleep apnea severity also seems to have a more abnormal P-wave terminal force V1, which, as I mentioned, is predictive of atrial fibrillation and ischemic stroke. So perhaps this may explain one of the mechanisms that mediate sleep apnea with atrial fibrillation as well as ischemic stroke. Lastly, we're getting into the last part. 68-year-old man with history of MI, ischemic cardiomyopathy, CABG, so has existing heart failure, ICD in place. Dr. Wayne Levy came to University of Minnesota when I was a fellow there, gave us a great presentation about the risk stratification of especially primary prevention in terms of ICD, how we can better stratify, risk stratify. But the question is, what is the impact of sleep apnea on ICD shocks, appropriate ICD shocks, surrogate marker of maybe malignant arrhythmia in patients with heart failure? This was one of the many studies that came out in the past 10 years from Dr. Cruz et al., where they showed that if you have sleep apnea, obstructive sleep apnea, or perhaps central sleep apnea, they didn't necessarily distinguish the two, and which is very difficult to do by any means. They showed that the appropriate shock rate is higher if you have and this was a primarily primary prevention patient cohort. So I did meta-analysis on a number of studies that came out in the past couple decades, and what I found was that indeed if you have sleep apnea, your chance of having appropriate ICD shocks is higher in patients with heart failure. Of course, this is a different discussion when it comes to general population. This is totally different patient population, no heart failure, general population. It's very difficult to study these population because the events is low and difficult to adjudicate these events. But again, Mayo Clinic has carried out this task where they used Olmsted County data and showed that some markers, not every markers, but some markers of perhaps sleep apnea seems to predict chance of having predict higher chance of having sudden cardiac death down the road. Published in 2013. I don't think it's easy to replicate this kind of studies down the road, but very rare study that's out there about linking sleep apnea with sudden cardiac death in general population. Okay, some circadian pattern that came out as well. For the sake of time, I'll move on. So with regards to circadian pattern of sudden death, again, this is in patients with heart failure, not with the general population. I think Dr. Poole was part of the investigator in this SCD-HEF trial, but where they showed that in their sub-study, secondary study, there was no morning, so-called morning peaking of appropriate shock rate in this patient population. The 6 a.m. to 12 p.m. peak of appropriate discharge of ICD, as they hypothesized. But what they did find was that at nighttime between 12 a.m. to 6 a.m., the rate of appropriate shock seems to go down. And there were all these comments that came after saying that, well, there was no measurement of sleep apnea because sleep apnea have shown in general population that there's a circadian, the shift in that your nocturnal sudden cardiac death risk goes higher compared to general population. I think this is more of a still a topic of interest and kind of interest than anything else. At this point, we don't have a lot of evidence behind this, so I won't keep talking about that. But I wanted to highlight a couple of things here before I conclude my presentation. So as you know, sleep medicine has come along in the past, I would say, couple decades, and now has a, Dr. McLellan rightly asked me whether there was actually a separate board. You know, of course we know about the fellowship, but whether there was a separate board, yes, there is a separate board within ABIM and within AAN in different societies. But it's truly multidisciplinary that gather interest group from various specialties. But in United States, it's predominantly, especially in private practice, come from the clinical sleep medicine workforce comes from pulmonary critical care. I'm trying to link this with what the presentation I've given you so far. Perhaps the link that I can give you is CPAP is perhaps the link between pulmonary/critical care and sleep medicine. Now, talking about psychiatry is in shortage. Psychiatry sleep specialist is in big shortage. But sleep disorders, sleep problems are heavily tied to mental disorder and psychiatric problems, as you can imagine. People who are suffering from depression and other anxieties and PTSD, you can name it. A lot of them have sleep issues and difficult to treat. So behavior psychology is also deeply involved, but they're also in shortage. What I heard last time was actual certified behavior sleep psychologists are less than 100 in the country or something like that. So you never get a response from them. You can refer them to them, CBT, cognitive behavior therapy for insomnia. There are some online programs out there now, but actually getting them to in-person therapy is extremely difficult. A lot of sleep doctors are from neurology, and the EEG component of the old concept of PSG perhaps signifies the importance of neurology and restless leg syndrome. All that pertains to neurology. Dental medicine is also part of the sleep medicine because dental, the mandibular advancement device, for example, and other oral device can certainly treat sleep apnea in certain cases. Pediatric and medicine, a lot of child sleep disorder issues. You probably have experienced your infant child or your toddler child want to share your bed with you. ENT also has a lot of stakeholdership in this field, and University of Washington is well known for it. But anyway, it's a multidisciplinary. So I have given you a number of slides that perhaps highlights the importance of cardiology being involved in sleep medicine. And we're busy. We have a lot of other interests, rightly, but I feel like we can do a little more as a field, and we can contribute more meaningfully to sleep medicine. So summary, sleep plays a very important role in blood pressure regulation and is important particularly important in resistant hypertension in terms of obstructive sleep apnea. No RCT so far has shown meaningful cardiovascular benefit. We only have a limited number of RCTs to begin with. And no RCT so far has shown the beneficial effect of sleep apnea treatment on the primary prevention of atrial fibrillation or even recurrence after ablation. Sleep apnea appears to have some impact on ICD shock in patients with heart failure, but the role in general population is uncertain. Sleep apnea assessment is not without controversy. I highlighted some of those points: central sleep apnea, obstructive sleep apnea, and one-night nature of sleep study. Whether that can truly represent your average sleep is always questionable. Also, subjective versus objective is also very important issues. A number of studies are now coming out suggesting that having subjective sleep complaints is what really makes a difference in terms of therapeutic effect and perhaps impact on cardiovascular system. So listen to your patient, whether they're complaining of sleep problems or not. If they're not really complaining, even when you ask appropriate questions, perhaps they're not on the top priority list of patient population that requires some referrals. So post-test question before you leave this place. So which future condition would be most strongly associated with untreated obstructive sleep apnea? I expanded the list a little bit to just give you a little confusion. I think I have answer to this, and my answer of this would be hypertension, partly because most of the studies and evidence are arising from hypertension studies. Now, second question, for those who are in busy EP practice, who were kind enough to come here today, which statement is supported by the strongest evidence? So sleep apnea increases the risk of new onset AFib. Sleep apnea increases the risk of AFib recurrence after catheter-based ablation. Treatment of sleep apnea reduces the recurrence of AFib after catheter-based ablation. Sleep apnea increases risk of stroke via atrial fibrillation burden. So they all have some truth to it, partly, but I have answered to this question as well, in my humble opinion. The strongest evidence so far is based on a number of observation studies that show that if you have sleep apnea, that seems to increase the risk of atrial fibrillation recurrence after catheter-based ablation. We don't have a lot good evidence behind the primary prevention of atrial fibrillation so far. Thanks so much for your attention. Open to any questions. if you have any. Yes, Dr. Levy.
Very nice presentation. Any comment about the limiting systems with these central sleep apnea?
Yes, so as you know, that has had a couple of trials. Suppressing central sleep apnea, very effective, no doubt. Translates into outcome, I guess there's something up in the air, but definitely improves the central sleep apnea, no doubt. And some of the studies have shown that there's symptomatic benefit as well, which I think is very important. I mean, we often fix ourselves on cardiovascular outcomes, but quality of life is very important, and that easily translates into outcomes that we often can't measure well. So I think it has a great promise. Now, it's a little invasive, phrenic nerve, but we shall see. We shall see. Yes, yes.
Is there anything we can tell our patients about preventing sleep apnea?
Yeah. So that's an excellent question. So of course, there's a bread and butter answers about that. Weight control and whatnot. Practically, positional sleep is very effective in most of the sleep apnea patients. At least it will lessen the severity of sleep apnea. No doubt, this is strikingly effective. It's just not highlighted in any meetings or any conferences or any talks. I don't know, because this is just no-brainer or it's just not fun to talk about sleep positions. By the way, sleep position, so if you sleep on your back, that's when you have bulk of sleep apnea for the most part. A lot of patients do have that. When you're sleeping on your side or when you're sleeping on your belly, your sleep apnea severity goes down dramatically in many patients. Now, some people already do that. They're kind of self-defense, they develop that, skills to move your body position to protect yourself from sleep apnea. But for those who like to sleep on their back, this is not easy. So that's why if you go to Amazon.com, you'll see some of the products that are out there, tennis ball jackets, whatnot. But I have experimented this on many of patients. Not easy. They don't want to be forced on certain sleep positions. But it's one of the simple way to prevent sleep apnea.
Is apnea hypoxemia?
Excellent question. Yeah.
It looks kind of like A1C and diabetes.
Well, I think A1C is actually very good. The AHI is all over the map, and that's controversy that I didn't go into. I don't think we have a sleep physician here. We can have debate over this, entire hour. Certainly not good, and that's one of the reasons why I'm inherently interested in other physiologic variables. Now, AHI, just for the sake of discussion, in 5,000 patients in our UVA sleep group, we compared AHI different sleep stage scorings, and the classification is like all over the map once you apply different rules. So Medicare follows this, clinicians follow that kind of as Bible. It's not without controversy. So thank you for that question. Yeah.
Sorry, we're out of time in the room. Thank you very much.
Thank you very much.